Thank you, Dr. Arun, for giving me this opportunity. I think we have a wonderful panel here with Dr. Devendra Sood. He's a very well-renowned glaucoma specialist. Dr. Arun Kshetrapal, a very well-known glaucoma and phaco-refractive surgeon. And then we have Dr. Lakshman Singh Jhala. He's a very renowned phaco surgeon from Udaipur. And Dr. Ankur Sinha, a very well-known glaucoma specialist. So I've been asked to talk on management of intraoperative and postoperative complications of cataract extraction and trabeculectomy. Unfortunately, I do not have a lot of, or fortunately, I do not have a lot of videos to support the complications occurring during phaco and trap surgeries, but we'll go and we'll make this session a very interactive. So we have already discussed when to consider combined surgery. So I usually follow 3 dictums. Now, patients with uncontrolled IOP in the absence of severe optic nerve damage should receive glaucoma surgery first, followed by cataract extraction a few months later. Combined surgery for me is best suited for a patient with visually significant cataract with uncontrolled glaucoma despite maximal medical therapy and or laser trabeculoplasty, and poor compliance with glaucoma medications can also be an issue to consider both the procedures together. So I usually follow these 3 dictums in my practice, and the few cases that Dr. Devendra Sood showed in his last slides are very important, because these are those cases where you can have a lot of times the vitreous loss, which could be a major fallacy for the success of the trap surgery. So there are certain potential advantages and disadvantages or intraoperative and postoperative complications. So we should discuss what are the potential advantages when we are doing a combined surgery. Now, the patient convenience is one very important factor, and convenience adds to compliance. It avoids the potential spike, the postoperative IOP spike, which can be seen after standalone cataract surgery, and especially for those cases with advanced optic neuropathy. Those patients which have high optic nerve damage can suffer because of high IOP spikes immediately after cataract surgery. Long-term control of IOP with glaucoma surgery and quick visual recovery from removal of significant cataract is one very important point which we can achieve after a combined surgery. But there are a lot of potential disadvantages which bounds to intraoperative and postoperative complications with combined then with standalone cataract or glaucoma surgery. Now, cataract surgery, when you consider in patients who already have glaucoma, is usually difficult because of certain points. Now, pupil is one of the major factors. Usually you will find a small pupil, non-dilating pupil, or chronically myosed pupil, and these pupils are difficult to address. Now, the combined procedures may be less effective than glaucoma surgery alone in controlling IOP, as we have seen few slides what Dr. Devendra showed, especially for eyes with advanced glaucoma damage. So you can have a good bleb when trap done alone as compared to a combined surgery where the bleb was not functioning. So different eyes react differently. So this is one case that I want to show you when you are addressing a patient with glaucoma. So here, though the surgery, you see a patient who has suffered a lot of multiple attacks of angle closure, landed into CACG and has high pressures. So we're taking this patient for combined surgery. But the point that I want to emphasize is you should be well acquainted with the use of pupil expanding devices. So what I'm using here is a Malugans ring, and it's easy to use. Put in viscoelastic, you need to make a main port, and as you see here, and this is how the device comes, and this can be loaded in the device, the dispensing device, and then slowly you can push this in the anterior chamber. Mind me, it has to be OVD all around, and sometimes the pupil is irregular and it is difficult to place in these patients. So you need to use your left hand also to guide this Malugans all around the pupillary rim. So a combination of good viscoelastic, your bimanual maneuvers, avoiding damage to the iris structure, to the cornea, and simultaneously to the lens. And that gives you a good view by which a phacoemulsification or a combined procedure can be carried out in these patients where you have small pupils. And mind me, a lot of times, a lot of these patients have small pupils which are difficult to be addressed. and then a routine phacoemulsification can be carried out. Now this can be combined with TRAB before single site or dual site, but I usually prefer doing a temporal phaco and a superior trabeculectomy. Now this is another video which shows a small pupil, and we have done a AGV and with cataract. So after addressing the AGV, we have put in the implant here, if you see here, and this is a white cataract, but the pupil again is bound down. There are a lot of synechias. Patient has had an uncontrolled pressures. This is a post-uveitic.
Just a minute, son. We have a lot of seats vacant here in the front. You can come in the front if you want. There's a lot of seats here. Please continue.
So here we are trying to use the iris hooks, and this is a simple device. These iris hooks can be passed, put in around the pupillary margin, and the pupil can be drawn up, and the tube has to be protected, and then a routine phacoemulsification can then be carried out in these patients. So this gives you a good view under trypan, and a phacoemulsification can then be carried out. So the features of safe surgery system to minimize complications, and to sum up for the complications, we know that we need to prevent hypotony, we need to prevent thin uncomfortable cystic blebs, and we need to prevent the limbal leaks of aqueous. Now how do you do that? You have to have adjustable sutures for the scleral flap that can be titrated if you want to prevent hypotony. You can have a continuous intraoperative infusion system to prevent intraoperative hypotony during the surgery. You can devise a small sclerostomy punch, as my colleague Dr. Arun has already given you tips on how to do a punch, and the fornix-based conjunctival flap to optimize construction of the scleral flap. Now when it comes to having good blebs, prevent thin uncomfortable cystic blebs, larger area of anti-metabolite treatment should be devised. Posterior diversion of aqueous by altering the scleral flap construction, a fornix-based flap to minimize posterior scarring, and the blebs location under the eyelid treatment is must. And for the preventing the limbal leaks, a corneal groove closure technique is a must, which can help you preventing limbal leaks. Now if you go back to literature, the study says the complications can be divided into early and late postoperative complications. And to name a few: hypotony, hyphema, the shallowing of the anterior chamber, the blab leaks, choroidal detachments, blebitis, persistent inflammation, PVDs or macular holes, aqueous misdirection syndromes, Dellen, decimate membrane detachment, Lance malposition, recurrent uveitis, stitch granuloma, and Tenon cyst endophthalmitis. So we'll put few of these complications which we commonly encounter once we do a combined surgery, and we'll discuss on the stage how to address them. So intraoperative complications, one of the most commonly encountered complications when we start the TRAB along with the cataract surgery is a conjunctival buttonhole. So Dr. Devendra, do you advise any key points to address for conjunctival buttonholing once you start the surgery? A lot of times you have intraoperative bleeding. So the choroidal hemorrhage can happen, and you feel the eye suddenly goes tight. There is a sudden increase in the firmness of the eye, the chambers get shallow, and there is forward movement of the intraocular contents, and you suddenly notice under the microscope there is loss of the red reflex. Now these are the warning signs that there is something coming up. There is the choroidal hemorrhage which is coming up. So Dr. Ankur, if unfortunately it happens, you're doing a surgery, high pressures, and then suddenly you see the loss of red reflex, how would you address this situation?